This lesson will provide a further exploration of oxygen supply and demand in the body. Understanding this in greater detail is fundamental to understanding the pathophysiology of shock states and how to resuscitate patients. So, the main theme here will be a graphic description of the relationship between oxygen supply and demand. So we'll draw a quick graph here. And on this axis, we will place V.O2, which is demand, and also consumption. On this axis, we will place DO2, which is oxygen delivery, which is the same as the amount that's being supplied. The units are the same, so we'll put some tick marks here to indicate increments of, say, 250 mils of oxygen per minute, either being consumed or delivered. And why we do this will make sense in a couple seconds. But let's first consider the determinants of V.O2 and DO2. DO2, as recall, was the content of arterial oxygen times the times cardiac output. And CaO2 involves hemoglobin concentration, saturations, and a constant. So essentially, the main constituent of that mixture is hemoglobin concentration times cardiac output. V.O2, also in mils per minute of oxygen, is based on what your activity level is. Are you running? Are you sleeping? What's your muscle mass? What's your size? Are you febrile? What's your metabolic rate? Are you hyperthyroid? Are you having an MH crisis? Are you in 4-point restraints in a jail, fighting, the restraints and consuming tons of oxygen with tons of muscle mass? Or are you basically sedated, maybe even paralyzed on a ventilator, not consuming much oxygen at all? So this is almost kind of an independent value that's determined by physiology, arousal, what you're doing, and how big you are. And oxygen delivery certainly is part of your constitution as well, how much blood you have and how well your heart is working. So let's take a situation where, let's say your body really wants to consume 1 liter per minute. And so 1 liter, 1, 2, 3, 4 is out here. But for some reason, your body, maybe because your hemoglobin content is limited or your cardiac output is limited, is only providing 250 mils of oxygen per minute. Well, despite the fact that this is what your body is demanding, this is what it's getting, and this is what it's, that's what it's consuming. And so your body has an oxygen debt. It really wants to have this much more oxygen. And therefore, when you want to have more oxygen and all of your cells are geared to be consuming that level of oxygen and you're not delivering it, you're undergoing anaerobic metabolism. So let's take another situation. Let's say your body now is delivering 500 mils of oxygen per minute, and another situation, 750, or an even 1 liter. And now we'll go out to 2 liters, 3 liters, etc. And so what you end up seeing when you look at these relationships is that for every level of oxygen demand, there is a curve that goes with that describes how well the body is supplying the oxygen that the body is demanding. And in this region, indicates whether there's an oxygen debt, whether the body really wishes it was consuming more, but it's not, and then degree of that debt, depending on what the body's doing as far as delivery. So often this curve is labeled with a couple terms. One is the critical oxygen delivery threshold. And this is the point at which the amount of oxygen consumption is limited by that that's delivered. And this part of the curve is called the oxygen-dependent part of the curve, and this part of the curve out here is the oxygen-independent part of the curve. So this is very important to know because in assessing critical illness, assessing endpoints of resuscitation, you really want to make sure that your body or your patient is living out here on this part of the curve, not down here in the oxygen-dependent part of the curve or the supply-dependent part of the curve. So looking at shock states, you can see that if you're losing blood and you're hemorrhaging, and that's part of your preload and therefore hurting your cardiac output as well, you're moving downward from the right side of this curve, leftward, and at risk of dropping below this threshold and creating a state of starvation of oxygen for your cells. That is incredibly dangerous. Same thing for cardiogenic shock, where your heart is not able to deliver enough blood and enough oxygen at the level that's being demanded. Again, if you've descended to this part of the curve here, that is a huge setup for organ dysfunction and cell necrosis. So how does mixed venous O2 saturation fall into this scheme? Can it tell us something about supply-demand relationships in the body? As you recall from the prior lesson, we asked the question, what does it mean when mixed venous O2 saturation changes? And the answer is that it could be explained by any change in any of the components in the supply-demand relationship. So it could mean that, let's say we're talking about a drop in mixed venous O2 sat. It could mean that it's an increase in V.O2 or a decrease in any of the components that comprise DO2, whether it's hemoglobin or its cardiac output. And so it's not that useful in the sense that a change can mean one of three things. Where it's helpful is when you know that you have a pretty constant hemoglobin and a pretty constant level of activity or oxygen metabolism, then you can deduce that some of the changes that you see in mixed venous O2 sat are due to changes in cardiac output. And then you have to figure out, well, what about cardiac output is changed? Is it the heart rate? Or is it the stroke volume? And if it's a stroke volume, is it preload? Is it afterload? Or is it contractility? And so then, your work continues on. So can we draw what is a change in mixed venous O2 saturation on this curve here? And the answer is yes. If you're dealing with, over a series of measurements, if you're dealing with a constant level of V.O2 and you therefore can draw one curve that describes where the body is over the course of serial measurements, and you're pretty convinced that, well, even if you have, so with a constant V.O2, any change in mixed venous O2 sat is actually movement either up or down the horizontal component of the curve. So this would be a decrease in mixed venous O2 sat. Whereas an increase in mixed venous O2 sat is moving rightward. So the other thing to consider here is, do some of our experiences and lab values that we commonly see clinically corroborate what has been presented here? And the answer is absolutely. So, for example, a normal mixed venous O2 saturation is 70%, which means of the blood that's left the arterial system, we'll describe 100% as a pizza with 4 pieces, only about a quarter of that has been consumed. And that certainly is consistent with most patients, basically, or us, living way out here on this part of the curve, which means that we can tolerate drops in hemoglobin. We can tolerate some drops in cardiac output, whether it's dehydration, whether it's higher afterload due to excitation, um, or need to maintain cerebral perfusion, etc. We have tons of latitude to move up and down these curves, as well as to increase our activity level and exist on much higher demand curves, and still, through all of that, our ability to metabolize oxygen is not being limited by delivery. So how about patients that have very low oxygen deliveries? And those would be patients who have traumatic blood loss, whether it's blunt or penetrating trauma, perforated ulcers, etc. They look very mottled. Their pulse oxes don't work. These patients are heavily vasoconstricted, and there's very little blood in their body. Some of the lab values that we see are very significant metabolic acidoses, lactate levels that are elevated, suggesting that glucose is being metabolized via an anaerobic pathway versus the aerobic pathway. And again, these are patients that have very slow capillary refill. When you analyze their blood values, once fluid shifts and resuscitations happen, they're very low. They're living down here, and they are in shock, and their cells are in dire straits, and if not properly resuscitated and very quickly, they're at a huge setup for having a anoxic injury. So hopefully this shows that some of the experience that you've seen, patients who are horribly deranged in metabolism, how you can imagine that those patients would be living down here on the supply-dependent part of the curve, whereas the body is really designed to have very flexible ability to deliver oxygen through huge range of physiology and activity levels. So we'll revisit this curve in another lesson when we talk about the pathophysiology of shock states.